Hi, everyone. My name is Anna Riley, and let's take a look at a brief introduction to nursing management during the labor and birth process. Using evidence based practice in our nursing management is essential because nurses are primarily the ones at the bedside, helping to make sure that both mother and baby are safe during the labor and birth process, and also providing a positive birth experience. The labor and birth process is a life-changing event, and so it's essential that we remember that when we approach our patients. We need to approach them holistically as well-rounded individuals with a multitude of needs, including physiologic needs, psychological needs, informational communication, needs for esteem and security, as well as medical needs and needs for their own autonomy. The U.S. maternal morbidity and mortality rates are appalling, and they're among the worst of any of the developed nations in the world. And so it's essential that we step up our care by providing in-depth maternal and fetal assessments, by providing adequate comfort and pain relief measures throughout each stage of the labor process, and finally, by tailoring our care appropriately for each stage of the labor, birth, and recovery process. First, let's look at some common maternal assessments done during the labor and birth process. In addition to maternal vital signs, vaginal examinations are commonly performed by the insertion of two sterilely gloved fingers into the vaginal canal. This helps us to assess for a few things. First, cervical dilation and effacement, or how much the cervix is expanding and thinning out. Second, fetal descent in the presenting part, or which part of the baby is coming down first and how low the baby has descended into the pelvis. Finally, vaginal examinations helps us to confirm if the membranes surrounding the baby have ruptured yet or not. It's also important to assess uterine contractions during labor, either externally by palpating with the fingertips on the woman's abdomen during contractions, or by monitoring internally with an internal pressure catheter. However, because of the increased risk of infection from internal monitoring, we generally save internal contraction monitoring for necessary cases. Another important maternal assessment that helps us determine the position of the baby is called Leopold's maneuvers. Leopold's maneuvers consist of 4 different steps, as shown on our makeshift Prego belly here. First, you stand next to the pregnant woman, facing towards her head. You use your hands to palpate at the top of the uterus called the fundus. If you feel a softer part that moves with the rest of the body when you move it, that's the buttocks. If it's hard, then that's the fetal head and baby is breech. Next, you move your hands down the side of the abdomen. When you feel one side that's firmer and smooth, that's the back. The other side with prominences that move, those are the limbs. That helps you determine which side the fetal back is on. Next, you take one hand and feel for the bottom part. If it's a firm part that doesn't give much squish to it, then that's the fetal head. If the part, it has more give to it and moves more, then it's the buttocks, and then baby is breech. Finally, you turn and face the woman's feet and run your hands down the side of the fetus. If you feel a hard part opposite the side of the back, that's the baby's chin, and baby is flexed. If you feel a hard part the same side as the back, then that's the back of the head, and baby's head is extended backwards. Also, feel to see if your hands come together. My hands come together easily in this situation, which shows that the baby is not descended into the pelvis. Several fetal assessments are performed throughout the course of labor. The first is the analysis of the amniotic fluid. After the rupture of membranes, we want it to remain clear and free of odors throughout labor. Otherwise, we may call for extra assistance at the time of delivery. Fetal scalp stimulation can be performed in order to assess for fetal heart rate acceleration from the stimulation. This helps to assure us of adequate CNS status in the fetus. Umbilical cord blood analysis can be performed after delivery in order to assess cord blood pH as well as other acid-base status markers. The most important and commonly used fetal assessment during labor is the analysis of the fetal heart rate, which can be performed intermittently or continuously. If done intermittently, the fetal heart rate should be assessed every 15 to 30 minutes during the first stage of labor, or every 5 to 15 minutes during the second or pushing stage of labor. Continuous fetal monitoring is very commonly used in hospitals, and this is accomplished with the placement of two monitors, either externally placed on the abdomen of the mother or internally, as shown in the picture on the right. One monitor monitors the baby's heart rate, and the second monitors contractions. When assessing the fetal heart rate, we look for a baseline between 110 and 160 beats per minute. And with that, we want to see a moderate amount of variability. That reassures us that the baby is adequately oxygenated. Now, looking at the strips shown on the lower right of this page, the top shows minimal variability, and that makes us question the oxygenation status of the baby. It would certainly require further assessment, as well as interventions if unchanged. On the bottom shows marked variability, which can cause problems largely because it can be difficult to assess the baseline with this type of strip. Now, on the left, we have a number of transient changes in the fetal heart rate, which are very common during labor as well. On the upper left is an acceleration, which we love to see. This reassures us of adequate oxygenation status in the fetus. On the upper right are early decelerations, called that because the bottom of the deceleration matches up with the top of the contraction. These often indicate that the fetal head is being squeezed, and these generally don't need any further intervention. The bottom right, on the other hand, shows late decelerations, called this because they come late compared to the contraction. The bottom of the deceleration comes after the top of the contraction. These indicate some sort of interruption in uteroplacental oxygenation towards the baby, and they always need some type of intervention, particularly when accompanied with a very minimal variability in the heart rate. Often a position change or extra fluid to the mother to increase blood supply to the baby are all that can be needed to fix these. Different from early and late decelerations are variable decelerations, as shown in the lower left-hand corner. These often indicate cord compression, and they may or may not be associated with contractions like the other types of decelerations. These can be fine if they only happen once in a while, but if they're repetitive, they will also need interventions to fix the problem. There are many different methods of non-pharmacologic comfort options and pain management during labor. And other than waiting until at least 39 weeks of gestation to induce labor, these can be some of the best ways of encouraging a physiologic birth. Some of these include hydrotherapy in a tub or shower, application of heat or cold according to the woman's preference, focusing attention on something positive as well as positive imagery, effleurage or light touch and massage, slowing down breathing techniques, acupuncture, and acupressure. Particularly for women experiencing back pain during labor, counter pressure on the sacrum can particularly help with that pain. Continuous labor support has been shown to be one of the best methods of improving pain relief as well as providing more positive birth experiences for women. And nurses can help to provide some of this support, particularly by encouraging frequent ambulation and position changes of the woman. This helps to encourage descent of the fetus into the pelvis, as well as provide more comfort for the woman. Some of the positions shown here on this slide can be quite comfortable during contractions. For women who would like medication to help with the pain of labor, we have many pharmacologic options to offer them. Systemic analgesia, such as opioids, are excellent options for early labor. Because they can depress the newborn, it is best not to give them within about 4 hours of delivery. Earlier than that is just fine. Inhaled analgesics are great options for a woman who wants to feel autonomy. Nitrous oxide is administered through a handheld device that the woman holds to her face to breathe in and then removes in between contractions. Regional analgesia, such as the epidural, is the most commonly one seen in hospitals in the United States. In fact, about 70% of women in U.S. hospitals get epidurals to help with labor pain. Options such as the spinal are often given for non-urgent C-sections, or a combination spinal epidural is often given for C-sections that are expected to last longer than average. For a woman who has labored and birthed without any type of pain medication, she still may require local infiltration, such as lidocaine, in the vaginal area after delivery, in order to help with the pain of any type of repair of lacerations or episiotomies. General anesthesia is given during C-sections, but it is usually reserved as a last resort for a woman who needs an urgent C-section and no other type of pain control will be able to be delivered in time. The most important thing to remember for pain relief in labor is that we need to respect our patients. We need to offer them the information they need to make informed decisions, and then we need to respect those decisions and the requests they make of us. Up until this point, we've primarily discussed nursing management during the first stage of labor, which is completed once the woman reaches 10 centimeters of dilation. At this point, she begins the second stage or pushing stage of labor. Current evidence supports delaying pushing until the woman feels the urge to push, or until 90 minutes after she has completed dilation. It also supports spontaneous pushing in the way and position that the mother chooses. It's important for the nurse to continue to monitor the fetal heart rate during the pushing time, especially so because this period is even more stressful than previous times of labor. The second stage of labor is done when the newborn is delivered, at which point it is the nurse's responsibility to dry and stimulate and suction the newborn as needed, and assess it for any extra interventions that it may need. The nurse also assigns APGAR scores at this time. After the delivery of the newborn comes the third stage of labor, or delivery of the placenta, and the fourth stage, which is the recovery and postpartum period. Immediate newborn care should be done in this time, such as keeping the baby skin to skin, keeping it warm and dry, and helping the mother to breastfeed whenever that is her preference. Her pain should be assessed and medications provided according to her preference. Her vital signs, especially blood pressure, should be taken every 15 minutes for the first hour after delivery. And her perineum should be assessed after laceration repair to check for any signs of hematoma. Because postpartum hemorrhage is one of the leading causes of maternal morbidity and mortality, it is essential to do frequent fundal and lochia assessments every 15 minutes for an hour after delivery and every half an hour for another hour after that. The fundus should palpate firm, midline, and at the level of the umbilicus or below. If it palpates off to the side, that is generally a sign that the bladder is full and should be emptied immediately, because a full bladder will prevent the uterus from contracting down appropriately and will increase the amount of bleeding. Lochia, or vaginal bleeding, should be assessed at the same time as each fundal check. Light to moderate bleeding is expected, but heavy bleeding or excessive clots should be reported to the provider immediately. Following the evidence-based practice recommendations in this presentation will help to provide a positive and safe labor and birth experience for your patients. Thank you.